Let's talk about heart disease in pregnancy. Cardiovascular disease is the leading cause of death in pregnant women. About 30% of all pregnancy-related deaths occurs in 100,000 pregnancies. Most common during pregnancy: heart failure, MI, arrhythmia, aortic dissection. Risk factors, there's 4: race, age, hypertension, and obesity. Race: blacks have 3 times the risk. Age: 40 plus year olds has 30 times higher risk than a 20-year-old. Hypertension: 13 times risk for MI and 8 times for heart failure. Obesity, especially if they have sleep apnea. Physiologic changes during pregnancy: BP decreases then increase in third trimester, increase in cardiac output and plasma volume, decrease in maternal systemic vascular resistance, increase hydrostatic pressure, and decrease alcoholic pressure and osmotic pressure postpartum, leading to pulmonary edema. 3 to 6 months to return to normal. Left ventricular end diastolic volume increases. Left and right ventricular mass increase by 50%. Increased risk of VTE, hypercoagulability, venous stasis, decreased venous outflow and compression of VIC, increased insulin resistance and elevated serum fatty acids. Preconception counseling for known cardiac issues. Gene mutation MYH7 causes cardiomyopathy. Assess for cardiovascular disease in antepartum and postpartum, with California improving healthcare response to cardiovascular disease in pregnancy and postpartum toolkit algorithm, which is figure 1. So if we have one symptom, one vital sign abnormality, and one risk factors, or any combination adding greater than 4, then you should obtain a EKG and a BNP. And then also consult MFM and cardiology. So what are the symptoms? Dyspnea, mild orthopnea, tachypnea, asthma unresponsive to treatment, palpitation, dizziness, syncope, chest pain, and dyspnea, suggesting of heart rate failure, arrhythmia, or coronary artery disease. Vital sign abnormalities include resting heart rate greater than or equal to 110, systolic blood pressure greater than or equal to 140, respiratory rate greater than or equal to 24, oxygen saturation less than 96, risk factors: greater than 40-year-old African American, pre-pregnancy obesity greater than 35 BMI, pre-existing diabetes, hypertension, substance abuse. Or if on physical exam you hear a loud murmur, or on the lungs there's basilar crackles. So EKG and BMP should be obtained. Echocardiogram plus or minus chest x-ray if heart failure or valve disease is suspected, and or if the BMP level is elevated. 24-hour Holter monitor if arrhythmia is suspected. And we should also consider chest x-ray, CBC, CMP, arterial blood gas, drug screen, TSH, and these patients should be followed up within a week. If results all come back negative and the signs and symptoms resolve, then patient is reassured and routine follow-up. So that was when you should suspect any type of cardiovascular disease. And then also we could use the modified WHO risk assessment model 1 to 4. This is really important as well. Let's take a look. So there is 1, 2, 3, 4, 5 different categories or risk stratifications, but there's only 4 classes because risk, the third category is risk class 2 and 3. So class 1 has only 2 to 5% risk of maternal cardiac event. And follow-up for this patient is cardiology evaluation once or twice during pregnancy. So class 1 is 2 to 5, so less than 5, let's just say that. Class 2 is less than 10, and then class 2 to 3 is less than, it's 19 or less. So 10, 20, and then class 3 is 20 to 27. And then class 4 is 27 or above maternal cardiac event rate. So for class 1, the follow-up is once or twice during pregnancy. Class 2 is every trimester. Class 2 to 3 is also every trimester. Class 3 is every 1 to 2 months with cardiology. Class 4 is every month minimum with cardiology. And also class 1 deliver at local hospital. Class 2 can deliver at local hospital. Class 2 to 3 should deliver at an appropriate level hospital with critical members of the pregnancy heart team available. Class 3 as well, appropriate level hospital. Class 4 also as appropriate level hospital. They shouldn't be pregnant in the first place. We should discuss abortion for these patients. So specific lesions for class 1, we have uncomplicated small pulmonary stenosis, patent ductus arteriosus or mitral valve prolapse. If the patient has successfully repaired simple lesions, atrial or ventricular septal defects, or there's an isolated atrial or ventricular ectopic beats, that's class 1. Class 2 is unoperated atrial or ventricular septal defect, repaired tetralogy of Fallot or aortic coarctation, most arrhythmia such as SVTs, Turner syndrome without congenital cardiac diseases. Class 2 and 3, mild left ventricular impairment. The ejection fraction is still greater than 45%. Hypertrophic cardiomyopathy, native or bioprosthetic valve disease. Marfan without aortic dissection, aortic dilatation. And if we have a bicuspid aortic valve, the aorta is less than 45 millimeter. If there's a atrial ventricular septal defect, so class 3 is ejection fraction 30 to 45%. Let's see, moderate mitral stenosis, severe asymptomatic aortic stenosis. If patient has Marfan, then the aortic dilation is 40 to 45 millimeter. If the patient has bicuspid aortic valve, it's less than 50 millimeter. Turner syndrome with aortic cardiac defects, tetralogy of Fallot less than 50 millimeter. Class 4, ejection fraction is less than 30. For and there's severe mitral stenosis, symptomatic aortic stenosis. For Marfan, the aortic dilation is greater than 45 millimeter. Tricuspid valve dilation of aorta is greater than 50. Tetralogy of Fallot greater than 50 millimeter as well. vascular allodynosis, severe coarctation, Fontan circulation with complications. So that was the modified WHO risk assessment. Indicated tests: if symptom or history of heart disease. Table 2 for signs and symptoms warrant further evaluation. I think you could use the California um, I guess it's not in here. Let's see, table 2. Oh, here. So patients warranting evaluation, non-emergent, will be self-reported symptoms of shortness of breath with mild exertion, persistent cough, chest pain is atypical, palpitations, brief self-limiting episodes, no lightheadedness or syncope, vasovagal syncope, mild to moderate fatigue, heart rate is less than 120, respiratory rate is less than 25, no visible JVP, if there is a systolic murmur, and moderate edema. If the patient has the following, patient needs to have prompt evaluation with the pregnancy heart team. If they had a history of CVD, if they have paroxysmal nocturnal dyspnea or orthopnea, bilateral chest infiltrates on X-ray, they have chest pain on minimal exertion or rest, unprovoked syncope, extreme fatigue, heart rate is greater than or equal to 120, respiratory rate is greater than or equal to 25, oxygen saturation is less than 95, JVP is 2 centimeter above the clavicle, loud systolic murmur or a diastolic murmur. The lungs, you can hear crackles, wheezing. So tests that we can do: brain natriuretic peptide is increase could mean heart failure if it's greater than 100 picogram per millimeter. Normal range increase is seen in pregnancy but rarely out of normal range. Normal range or low BNP is useful for excluding cardiac decompensation. Increased BNP from second trimester appear to predict adverse events. Baseline and serial BNP in each trimester can assist in decision making in high risk patients. Troponin All pregnant and postpartum patients with chest pain should have troponin and EKG. Troponin can be mildly elevated in postpartum with preeclampsia patients, patients with acute PE or chronic renal disease. EKG ST and T wave changes can be found in about 15% of pregnant women. However, all EKG abnormalities should be further evaluated. Chest X-ray with abdominal shield. If shortness of breath, patient should get a chest X-ray. Echocardiogram. Patient with pulmonary hypertension or unexplained oxygen desaturation should have echo before pregnancy. Any woman with cardiac history, congenital or acquired, should have echo done. Exercise stress test should be done in patient with known heart disease planning on pregnancy. Submaximal exercise test in asymptomatic patients with suspected heart disease. You can do this for patients who are already pregnant by using 80% of max heart rate. CT if PE or aortic dissection is suspected. Iodinated contrast is not teratogenic but can cross the placenta and cause a transient depression effect on the fetal thyroid. Less than 1% is absorbed through the infant GI through breastfeeding. Therefore, breastfeeding can be continued without interruption if contrast is administered. MRI can be used if echo is not diagnostic for ventricular function. Gadolinium should be limited in pregnant women only if significant improvement in diagnosis. Breastfeeding should not be interrupted. Holter monitor, helpful for assessing palpitations, lightheadedness, syncope during pregnancy. D-dimer not useful. Pre-existing maternal cardiac disease with highest effect on pregnancy. Number one is definitely pulmonary artery hypertension. If the mean pressure is greater than 25 millimeter mercury at rest, then you have pulmonary artery hypertension. Mortality rate is 20%. Pregnancy is not recommended. Congenital heart diseases. Any congenital heart disease associated with pulmonary hypertension, severe left-sided heart obstruction, severe ventricular dysfunction, cyanosis, failing Fontan circulation, or complex arrhythmias. Genetic disorders associated with congenital heart is Noonan, Downs, Holt-Oram, and 22q11 microdeletion. Non-congenital valvular diseases, mitral valve prolapse, bioprosthetic valve prosthesis, valve disease related to infectious endocarditis. Echo and stress test is recommended. Mechanical valve prosthesis should be on low dose aspirin. Endocarditis prophylaxis around the time of delivery. For pre-existing dilated cardiomyopathy, baseline BNP, echo for ejection fraction, Stress tests should be done for pre-pregnancy. High rate of cardiovascular event during pregnancy up to 40%. If the ejection fraction is less than 30, severe valvular stenosis, Marfan with aortic diameter of greater than 45 millimeter, bicuspid aortic valve diameter greater than 50 should not be pregnant. Hypertrophic cardiomyopathy, 2% prevalence, most common genetic cardiac defect. Cardiovascular complications are common. Aortic aneurysm disease and dissection, echo and MRI to evaluate the size and location. Most occur on the ascending aorta. Allodynius should avoid pregnancy. Patient often treated with beta blockers. Surgical and percutaneous intervention for aortic aneurysm or dissection during pregnancy or postpartum is rarely needed. Table 6 for management strategy. So let's take a look at table 6 again. Alright, table 6. Okay, for Marfan syndrome, if the patient has normal size aorta, we do surveillance every trimester and the patient is delivered vaginal. If the dilated aorta is 40, is a dilated ascending aorta less than 40 millimeter, surveillance should be every 6 weeks. Delivery can be vaginal. If the ascending aorta is 40 to 45 millimeter, then surveillance should be 4 weeks and delivery mode should be C-section. Ascending aorta greater than 45 millimeter, prophylactic aortic surgery before or during pregnancy for rapid growth. C-section should be offered. Onto bicuspid aortic valve. If the ascending aorta is less than 45, surveillance 4 to 6 weeks. Delivery mode vaginal. Ascending aorta 45 to 50, surveillance rate is 4 weeks and patient should be delivered via C-section. Ascending aorta greater than 50, aortic surgery before or during pregnancy for rapid growth and patient should be C-sectioned. Atrial arrhythmias. Most common arrhythmia during pregnancy are premature atrial beats and paroxysmal supraventricular tachycardia. Likely can be treated with meds. Ventricular arrhythmias is rare in pregnancy, most common if no structural issues is a ventricular outflow tract ventricular tachycardia treated with beta blocker or verapamil. Long QT syndrome at risk for ventricular tachycardia, treat with beta blocker. Peripartum cardiomyopathy occurs around 0.5 per 100 live birth. Non-ischemic, presents late in pregnancy or first few months of postpartum. Ejection fraction less than 45% with no history of vascular problems can happen. Overall rate of death and cardiac transplant for a woman presenting with peripartum cardiomyopathy is 10% by 1 year postpartum. Risk factors: blacks, AMA, twins, gestational hypertension or preeclampsia, high risk of recurrence rate 20%. Echo is most important diagnostic test. Vaginal delivery is not contraindicated. Nearly 90% of women with initial ejection fraction greater than 30% recover completely. Low EF is associated with higher mortality and morbidity. 50% of patients with peripartum cardiomyopathy will recover completely, if not return to normal in 6 months. Full recovery is less. After full recovery, ACE inhibitor, beta blocker continued for 1 year, 20% recurrence rate. MI. Ischemic heart complicates 8 out of 100,000 pregnancies. This is 10% mortality rate. Coronary artery dissection, most common cause of pregnancy-related acute coronary syndrome. Initial management: O2, nitrates, ASA, IV heparin, beta blocker, coronary angiography. Maternal cardiac arrest. Hemorrhage is the most common cause, 40%. Amniotic fluid embolism, 15%. Other categories in alphabetical order: anesthesia complications, bleeding, cardiovascular disease, drugs, embolism, fever, general, as in metabolic or electrolytes, hypertensive, including stroke. A, B, C, D, E, F, G, H. 6 key concepts during resuscitation: back mask, ventilation with 100% oxygen and early intubation with small endotracheal tubes. Aortal caval compression by the uterus greater than 20 weeks should be reduced with 1 or 2 hands manually to the push uterus to the left, or left uterine displacement while patient remains in full supine position. Simultaneous concurrent interventions are recommended. Fetal delivery should be initiated in parallel with maternal resuscitative efforts. High quality chest compression, 100 to 120 per minute at the middle lower sternum. Oxygen primary goal with ratio of 30 to 2. Giving oxygen circulation is a primary goal with chest compression and ventilation efforts ratio of 30 to 2. Perimortem C-section or resuscitative hysterotomy. If 20 plus weeks and initial intervention not successful, target delivery time less than 5 minutes. Up to 25 minutes for delivery time has been shown to be beneficial. Antepartum management principles: fetal echo if patient has congenital heart disease. Risk of fetal congenital heart disease is around 10%. Echo should be performed in any pregnant or postpartum woman with pulmonary edema, possibly due to peripartum cardiomyopathy or preeclampsia. So echo on everybody with pulmonary edema. Intrapartum management prophylaxis with low molecular weight heparin should be stopped 12 weeks before induction or C-section, 24 hours if the patient is on therapeutic dose of heparin. For unfractionated heparin of 7500 or more, BID, 12-hour interval, as well as evaluation of coagulation status with the labs should be done. Most common complication intrapartum is pulmonary edema or arrhythmia. OB anesthesia principles. Arrhythmia are significantly reduced with epidural use. Immediately postpartum, peripartum cardiomyopathy is leading cause of late postpartum death, about 25%. Aortic dissection and acute coronary syndrome typically diagnosed in early postpartum period. Acute coronary syndrome is 3 times higher compared to non-pregnant patients. 5 out of 100,000 deliveries. BMI 35 or more. Weight-based heparin achieves higher anti-XA concentration. We can do 0.5 milligrams per kilo of enoxaparin every 12 hours. Woman whose cumulative lifetime duration of breastfeeding is 6 months are 10% less likely to develop cardiovascular disease. High-risk patients should have had a evaluation at 30-month postpartum. Contraception use, IUD is recommended. Expulsion increase immediate postpartum is 20%. Progesterone-only contraceptive appears to be safe. Lower efficacy with oral progesterone pills, about 10% failure. Combined can increase fluid retention. Various annual failure rate. Fertility awareness method is 25%. Withdrawal is 20%. Spermicide is 30%. Female and male condom is 20%. Diaphragm is 15%. Ongoing care. Hypertensive disease of the pregnancy compared to normotensive patients. These patients have 4 times the risk of developing chronic hypertension, 4 times risk for heart failure, 80% increased risk of stroke, 10 times risk of end-stage renal disease, 2 times risk of atrial arrhythmia, coronary disease, and mortality. 3-month follow-up recommendation if patient had these during pregnancy: hypertension, GDM, IUGR, preterm birth, placental abruption, obesity, sleep apnea, 40 years or older. Tests that should be done when they return: cholesterol or lipid profile, fasting glucose, or 2-hour urine PC ratio. Repeat blood pressure or lipid profile in 6 to 12 months. If abnormal, then they should be started on medication.